So tonight we have Dr. Mauro Alvarez. He's a third-year resident at the Robles program. He visited Hospital de la Familia. And can you tell us a little bit about yourself, Mauro? Well, what is your interest in ophthalmology?
Good night, everyone. My name is Mauro Alvarez Burgos. I'm from Ecuador. In this moment, I'm a third-year ophthalmology resident in the Rodolfo Robles Valverde Hospital. In this moment, I'm interested in the specialty of glaucoma, retina, or neuroophthalmology.
Well, that's a broad. But what do you do in your free time? What do you?
Okay, in my free time, I like read different books, no only medicine, magic lanes, for example, novels, play soccer, do gym. That
He likes
Whatever.
astrology.
Oh yes, I like astrology. I have a
Um,
telescope and too in my free time I like see the sky with my telescope.
Nice. Okay. So now we have a bigger audience. So, do you want to start, Mauro? You know, you're sharing already, so you can start your presentation.
Okay.
Mhm.
Okay. Okay, good night, everyone. I'm gonna talk about traumatic optic neuropathy. I'm gonna introduce you a male 24 years old patient who came to consult in March 22. He's a farmer from La Blanca, San Marcos, Guatemala. He has no past medical history and vital signs were normal. Chief complaint, he came to us complaining about vision loss in the left eye, about 25 days of evolution secondary to a motorcycle accident where there was loss of consciousness. The visual acuity was 20/20 in the right eye and no light perception in the left eye. The patient refraction was plano in the right eye and mild myopia in the left eye with 0.25 of astigmatism. At the slit lamp, we found that the right eye was normal, but we found ecchymosis on the left eye with temporal subconjunctival hemorrhage. Cornea was clear and anterior chamber deep. We found a normal iris with relative afferent pupillary defect in the left eye and lens was normal. It's clear. The intraocular pressure was 13 and 17 in the right and left eye respectively. Okay, in this picture, we can see the area of the impact here on the left side of the face. And in this slide, in this video, we can see the relative afferent pupillary defect in the left eye with the swinging light pupillary disc. Now we can see how a relative afferent pupillary defect on the left eye is present. It's in the left eye. Okay. So a relative foreign pupillary effect can be explained as the absence of the motor reflex with the persistence of the consensual reflex, whereby we have a paradox dilation in the affected eye when we shine a light on that eye. This usually occurs when there is a damage to the optic nerve or any part of its trajectory before reaching the lateral geniculate body. Okay, at the examination with indirect ophthalmoscopy, we found a normal retina with a 0.5 optic nerve cupping in the right eye. And in the left eye, we found the retina was flat with a normal macula, but a generalized failure of the nerve with a 0.7 optic nerve cupping. This indicates that there is already atrophy of the left optic disc. We were able to obtain three-dimensional reconstruction image using a tomography. We can see a fracture of the frontal bone where the bone fragments compromise the frontal, ethmoid, and sphenoid sinus. The accident was in motorcycle. So we decide to keep him under observation and schedule a check-up appointment and refer to traumatology service and protection glass. Now I'm going to talk about the pathology. So traumatic optic neuropathy is a condition in which acute injury to the optic nerve from direct or indirect trauma results in vision loss. The severity of optic nerve damage in traumatic optic neuropathy may range from simple contusion to complete avulsion of the optic nerve. It is more common in younger males in the 85% of the case. The main causes are vehicle accidents, bike accidents, falls, assaults, and abusive injury in infants. The pathophysiology results from shearing injury in the optic nerve due to blunt head trauma, with the intracanalicular segment being identified as the most susceptible. External force deform or fracture the narrow optic canal, subjecting the optic nerve to shear stress and vascular compromise. So, external force deform this shear force leads to secondary retinal ganglion cell damage. So the severity of traumatic optic neuropathy is determined by the limited regenerative capacity of the optic nerve, leading to the rapid loss of retinal ganglion cells within 2 weeks through apoptosis. The axonal degeneration and retinal ganglion cells death can lead to structural and functional loss of the optic nerve. The diagnosis is primarily clinical and is based on different tools like the history, signs and symptoms, physical examination, and imaging tests. We should ask for visual dysfunction or visual loss after blunt or penetrating head trauma. The history and subjective complaints may be delayed due to the impact of and treatment for other concomitant head injuries or other systemic injuries. In the symptoms, patients may report vision loss, visual field defects, decreased color perception, pain, and to a scotoma. The initial external eye exam may show signs of orbital trauma or fracture like soft tissue edema, hematoma, ecchymosis, step-off on palpation of orbital ring, decreased visual acuity, and a relative afferent pupillary defect are also seen. On fundoscopy, the initial optic nerve head asement may be normal, but signs of optic atrophy will be seen in 3 to 6 weeks after trauma. Clinicians should exclude a penetrating or perforating globe injury in case of presumed traumatic optic neuropathy. There are some tests that we can use in the management and the diagnosis of traumatic optic neuropathy. It is important to obtain neuroimaging, usually a CT, of the orbit with coronal and axial thin sections through the optic canal are crucial to visualize the optic nerve as well as the optic canal and carefully evaluate for evidence of fracture. Automated visual field testing, such as a Humphrey, can be used to characterize visual field effects, scotomas in patients with traumatic optic neuropathy in acuity remains adequate for such testing. And also, visual evoked potential can be used to characterize the electrical activity of the optic nerve. In the differential diagnosis, we must consider posterior ischemic optic neuropathy, optic neuritis, optic nerve avulsion, non-organic vision loss, pre, intra, or subretinal hemorrhage, choroidal rupture, or commotion retina. The management of traumatic optic neuropathy is controversial, and so far data in the literature have not shown any treatment to be superior to observation. In fact, spontaneous recovery has been reported in at least 15 to 30% of patients, and one study showed a 40% rate of spontaneous visual improvement in children with traumatic optic neuropathy. The medical therapy, high-dose intravenous steroids can be considered for the treatment, but recent studies have raised doubts about their efficacy, with no convincing evidence suggesting that steroids provide more visual benefit than observation alone. The erythropoietin has shown promise as a potential treatment, because the erythropoietin has demonstrated protective effects on injured retinal ganglion cells by inhibiting caspase 3 activity. The surgical treatment, surgical decompression can be considered in case of traumatic optic neuropathy with evidence of optic nerve compression. The presence of bony fragments compressing the optic nerve or a hematoma near of the optic nerve, compressive retroorbital hemorrhage, or blood in the optic nerve sheath. The optimal timing of intervention remains a subject of debate. Some studies suggest the intervention within 48 hours or 3 days of injury may yield better outcomes, while others have reported beneficial results with surgery within 7 days. In the prognosis is dependent on the extent of injury to the optic nerve. In patients with no light perception vision, the prognosis is bad, is very bad. And in patients with better vision may improve by 1 or 2 lines of vision. And so that is all. Thank you.
Thank you, Moto. That was a quick revision of trauma. So in your appraisal of the case, what do you think was the mechanism? Can you tell us?
Mm.
Mauro?
In this case, the mechanism, for example,
Mhm.
for broken of the optic canal or the fracture of the sphenoid, in this case, the mechanism for that, the energy of the strike damage the optic nerve in the area intracanalicular area.
Yeah, probably that was the cause, right? And he came in because he didn't see anything, or did somebody bring him in? What was his complaint?
Mm,
You know? Do you remember? I mean, I'm just curious. Did he come in because he was?
no, he come to the hospital.
Oh, okay.
I think I saw that patient and I remember that he had the accident and he decided to come into the clinic because he couldn't see at all after he was like released from the hospital. So that's why he decided to come. That was like his main complaint. He
Yeah.
couldn't.
Mhm. Okay. Good.
Mauro, can you show the photograph that you had of the reconstruction of the skull using the tomography?
Yes.
First of all, it's an amazing image.
Yeah.
Yeah. Was that available to was that from Robles or was that from a local where was that from? I've never seen that produced in any of our facilities.
Uh, in a private center near of the Hospital de la Familia, and
Really?
he,
Wow.
yes,
And interestingly, you can see the fracture to the frontal bone, the
Yeah.
superiorly, and it doesn't show any other. You don't see any fracture to. I guess you say the ethmoids were read out as being fractured. That makes sense, but you don't see any other injury um, in this image here. So that really speaks to your other slide where it's just the traumatic force. I just shared an article that reviews the forces as they go through the skull with various types of injuries. And I think it's fascinating that concussive injury can cause that much damage to the nerve, um, as seen by this case. I'm interested to, whether other people have seen cases that are similar. The one that strikes me from my experience was a suicide, where the bullet went through and through and obviously took the patient's life, but they donated their eyes for corneal transplantation, and both of the corneas failed because even though they looked perfect on microscope, the concussive injury wiped out the corneal endothelium and also presumably, blinded the patient in the process of the bullet going through the skull. But are there other injuries that people have seen that are surprising in how small they were and yet how devastating they were to the optic nerve? That's my question.
When I was a resident, I saw a patient. I was called to see a patient who had a small lesion of periorbital, and he was bleeding, and he complained that somebody had stabbed him, and he couldn't see out of that eye. And it turned out, after interrogating him, he was under the influence of alcohol, so we had to wait a while. I'm not sure how you say that in English, but it's un verduguillo. So it's a very fine, very long type of knife. And somebody had stabbed him, and he had a very small, like a less than a centimeter incision right beside the eye. And he had just gone in, cut the optic nerve, and come out clean. I mean, it didn't hit the eye. It just went right on the bone, and it slit the optic nerve, and it came out. He had obviously a relative afferent pupillary defect, and nothing else. We just, at that time, we did put a stitch on the skin, and we didn't do anything else. It was just amazing how that small incision, he had lost his vision immediately. So
that patient probably had I guess the equivalent of a central retinal artery occlusion also, probably, and a pale must have had complete retinal pallor. And
yeah. We saw, it was just a white retina, and it was all nothing. There was nothing really to see, and nothing to do. So yeah, that was a weird case. All those weird cases like kind of stick to you, and you remember.
And I guess one last question I have is, can you see, and I don't know the answer to this, but can you see an afferent pupillary defect improve over the course of a week or two after a initial blunt injury? Anyone?
It kind of makes sense if you treat him with steroids, and it was just a edema of the nerve, and there was no piston kind of rupture of all the circulation of the optic nerve. It was just edema, and there's just the afferent I would see it probably improve a little bit, but I mean, it makes sense in my head that it wouldn't improve, but
that it can improve. Yeah. A quick search while I'm talking shows that there are cases. I think like an MS optic neuritis.
Yeah. All right.
Thanks, Mauro.
Thank you, Mauro. If there's no other comment from anybody.
Thank you.
The only other comment I'd make is, you guys.
Thank you all for the opportunity to be a part of Hospital de la Familia and to be able to have lived all these great moments in San Marcos. Also, thank you for letting me share this presentation with you tonight. Thank you.
Thank you. Rupert, you were saying? Were you saying something?
I was just saying that the other thing that really remarked is how many times at the hospital or in my own free clinic that it's written down that there's no light perception, and they're not actually no light perception. They may be hand motion, they may be light perception. Just a comment that if you see that in the chart, I think it behooves every one of us to go back and really such a far-reaching impact on what we do going forward, or what we, it is not uncommon to see that at the hospital, and they're not actually light perception. They're not actually no light perception. They have some light perception.
Rupert, that's a great point. can I second what you just said? Because whenever I see NLP, I always check it again, unless I wrote it. And even then, sometimes I'll check it again. Because that's because that's a big that has a massive impact on what we do. Like even a dense cataract, they always say NLP. That's why checking that pupil is so important. Because if it's NLP and a 4+ apparent pupillary defect, that's no vision. But if it's a normal pupil and no light perception, then it's somebody who just wants to have surgery, right?
Yeah.
So, yeah, that's great. Thanks. Great point.
And also proves the point of using a helmet.
Yeah.
And I think there's also a really big psychological difference. Yeah.
Thank
All
you.
right, guys, if there's no other comment, thank you. It was a quick night tonight. Thanks, everybody. See you next week.
All right. Bye-bye.
Bye.
Goodbye.